1902, the Biologics Control Act was the first regulation that actually existed related to vaccines. Smallpox vaccine was in use at the time, and there was no regulation at all in the United States about the manufacturing of products. And why was that? Because drugs were not commercially manufactured back at that time. Pharmaceuticals largely were compounded by pharmacists in local pharmacies. They made things from scratch based on a doctor's prescription order. But smallpox vaccine was distributed and it was contaminated in certain cases. And that led to the US government deciding that we needed to start regulating the manufacture of biologics. And that was in 1902. That was, in essence, the creation of the National Institutes of Health. That's when the National Institutes of Health was born, not as a research organization, but as a quality control organization was really what it was created as. In 1944, some of you who are public health gurus will know this particular story. We had the Cutter incident that happened. So polio vaccine, inactivated polio vaccine, was authorized for use in the U.S. and there were 5 manufacturers that the FDA authorized immediately to produce polio vaccine, and one of those was called the Cutter Corporation, based in St. Louis, Missouri. And the Cutter Corporation failed in their manufacturing process to use formaldehyde to inactivate the polio virus. And so what happened is a bunch of kids were injected with live polio virus, and instead of being injected with inactivated polio vaccine. And that led to the U.S. Public Health Services Act, which has stood the test of time and become the regulation by which the manufacture of biologics and quality control of biologics has existed in this country largely. We have not had an incident in contamination of the production of vaccines of any substantial manner since that time because our system has controlled it. The other thing I want to point out to you is that the vaccine development process in the United States typically is a very long process. And it is very important for you all to realize how long that process takes. It is not a set amount of time. For example, it's not that, okay, it takes 4 years or 5 years or 3 years or 10 years to get a vaccine from the conceptual stage to the marketplace. It really is dependent upon the vaccine that we're trying to develop and the disease we're trying to prevent. To give you the best illustration I know to give you is the plague. There has been an effort to try to create a vaccine against Yersinia pestis since 1895. Vaccines have been under development since 1895. And there have been on again, off again attempts to create a vaccine, and there's nothing successful has come. But in 2016, there was an outbreak of Yersinia pestis. I think it was on Easter Island, if I'm not mistaken. It was the Easter Island epidemic. And so vaccination efforts for Yersinia pestis pulled up again. So if Yersinia pestis ever comes to market, God forbid anybody think it was fast. It was not fast. It's going to be, it will have taken years. The point here is that there is a process that we follow, and it is not a time-dependent process. It's a process-dependent that has several steps that must be met in order for vaccines to come to the market here. Now, what's acceptable for endpoints? I'm telling you this as community advocates because you need to understand people are worried about how fast or how slow vaccines come to market. And the issue is not fast or slow, it's about the scientific rigor that goes into the creation of the bringing of vaccines to market. That's really what is so critical to understand. For vaccines, it's a little different than other drugs. For most vaccines for which we've not had a vaccine on the market, initially, to bring a vaccine to market for an infectious disease, what the FDA standard is immunogenicity. In other words, the degree to which your body produces antibodies that are believed to fight the infection that the vaccine was designed to prevent. And immunogenicity and correlates of protection, in other words, markers of what we think will protect, is typically enough to get a vaccine to market. And we can use several examples of vaccines that we currently have to market that were brought to market based upon immunogenicity data. For example, one that you're very familiar with is Prevnar 13. So Prevnar 13, the conjugate vaccine for the serotypes that were not in Prevnar 7, the immunogenicity data or correlates of protection were what was necessary to bring the vaccine to market. The FDA then requires the manufacturers to engage in clinical research aftermarket to determine what the actual effectiveness, real world effectiveness or efficacy controlled clinical trials are. And so that was what was required of that manufacturer in that particular case. We have the same thing has happened with multiple different vaccines. Now, once a vaccine's on the market and another company wants to bring a vaccine onto market to do the same thing, then what the FDA uses as its standard is a non-inferiority of immune response. So one vaccine's already there and another vaccine wants to come into market, then you have to prove that your vaccine works at least as well in producing an immune response as the one that's already there. Does that make sense? So that's the standard. Efficacy and effectiveness are the words, however, that get thrown around all the time in the public sphere and in press releases and in so forth and so on. And these two terms do not mean the same thing. Efficacy and effectiveness are not the same term. Efficacy is what you achieve when you do a controlled clinical trial. How well does this vaccine work to prevent the illness that it was designed to prevent prospectively with a control group where some people get the vaccine and some people don't? And that's efficacy. How well did the vaccine work? Or this vaccine compared to this vaccine, how well did it work? Effectiveness is after something's brought to market and in the real world, how well is it working to reduce the incidence of disease? We have tons of effectiveness data relative to COVID vaccines as a good example. We did not have a lot of data about efficacy. We had some data when the vaccines were brought to market, but we now have a ton of data showing that the vaccine's effectiveness exists for some period of time. So I just want to make that the case. The other thing that's very important for you to understand and for consumers to understand is that these agencies of the federal government, the FDA and CDC, don't make decisions in a vacuum. They have external expert panels that help them. And so the FDA has something called the Vaccines and Related Biologics Advisory Committee, which is comprised of about 40 or 45 healthcare professionals, mostly scientists, immunologists, basic scientists, and physicians who've done significant research in vaccines. And the rule is that those individuals cannot be encumbered with conflicts of interest with vaccine manufacturers, or they can't vote, or they can't provide advice. So they can't have financial relationships. And that's very, very important. The FDA, these committees are advisory, but as you can see in 2021, the FDA accepted 85% of the recommendations from their advisory committees across the board, not just the Vaccines Advisory Committee. 10% they accepted in part and 5% not at all. But generally speaking, these external advisory boards have tremendous influence over the policies that get set by FDA and CDC. So I've given you a graphic that you can refer to later about the life cycle of vaccines. And what actually happened during COVID vaccine is that the steps all happened. But if you listen to the news media, you would think that the steps didn't happen, because that's not the narrative that was floating around that we as public health professionals had to fight against. What we had to fight against is the vaccines coming to market too fast. Well, the vaccine it didn't come to market too fast, and I won't rehash all of that, but I will talk to you about what we learned during the pandemic that from vaccine processes that is important for us in the future. As I said, the CDC also engages experts. That's the Advisory Committee on Immunization Practices. Same rules. There are 15 voting members of the ACIP. There are another 30 liaison members that are non-voting of the ACIP. The 15 voting members can have no financial relationships with the pharmaceutical manufacturers that are developing vaccines. So you just need to have some confidence that these are really independent groups that have the best interest of consumers at heart. That's their purpose. I also want to tell you that we have in the U.S. the best safety signaling system anywhere in the world as it relates to vaccines. It was the best before the pandemic. It's even better now. The vaccine adverse event reporting system is a system that was designed for anyone to report any adverse event, no matter how mild or how severe, that might have occurred after vaccination, even if the individual isn't sure if the vaccine caused it or not. Consumers can report events that happen with themselves to the vaccine adverse event reporting system, and any healthcare provider can as well. And it's the FDA's responsibility and the CDC's responsibility to determine which of those things were causative and which were not. So those VAERS reports can come from anyone. There's also something called the Vaccine Safety Data Link system that's a real-time system to the CDC from several institutions across the country, mostly Kaiser healthcare systems, who have real-time controlled records and can share vaccine safety signals that exist. And that's monitored on a regular basis. Actually, it's monitored on a daily basis by the CDC. That vaccine safety rapid cycle analysis occurs. And in fact, when we saw the first incidence of myocarditis and pericarditis with mRNA COVID vaccines, it was actually the vaccine safety data link that gave us the first signal that that might be an issue and raise the awareness. So I just point that out. And of course, everybody in this room is very familiar with vSafe, a new system that was put into place just for the COVID vaccines. But I think the CDC's aspiration is that this will be a system that can be used for other vaccines going into the future to help with real-time safety monitoring and with consumers. So very important. And you all know about vSafe, so I'm not going to spend any time on vSafe. Well, let's get to the politics part, because that's the fun part. Okay, let's talk about the politics. Yeah, my wife might have been right. I'm trying to get through it, so in a reasonable amount of time. One of the things is that with politics, never let a crisis go to waste. It doesn't matter which side of the aisle you're on. There's a way to spin everything. Everything gets spun. And so it's almost been fun to watch how politicians and news media people that take one side or the other will spin things. And as a public health person, I worked with the Jefferson County, Alabama Department of Public Health for years and years before I moved to California. So I've worked in public health departments. I understand all of the great work that lifetime career public health officials put in. And it almost makes you want to pull your hair out when you hear the politics, okay? But let's set that aside for just a moment and say, what has this taught us? Has it taught us anything as public health people, as healthcare providers, as community activists to try to get immunizations in people's arms? What can we learn from the politics? Okay, well, first of all, flashy names catch headlines, okay? So Operation Warp Speed. Man, that's a lot in 3 words. That's a whole lot in 3 words. And boy, it got people's attention, didn't it? Yep, it got people's attention. Well, flashy words are meant to be able to secure votes, okay? What really matters is what happened underneath the flashy words. What was it that was going on behind the scenes at HHS, at FDA, at CDC? Were there any things that were happening differently as a result of the pandemic? You know, the president who was seated at the time the pandemic hit, that just happens to be who the president was. And so my guess is that no matter who the president was, we would have had some interesting 3-word name. It wouldn't have mattered who the president was. What is very interesting is that if you look at the policies that were put into place, they were put into place actually by CDC and FDA. They really weren't put in place by the politicians. It were the public health officials who know how our system operates day in and day out, who adapted our system to be able to respond. Now, that doesn't mean they didn't get pressures from the politicians. They get those pressures. But I would just say, even as the presidential transition happened, my colleagues at the CDC have reiterated this to me many times over, that functionally the day-to-day operations really are no different for what they do. And I know at least one of our colleagues here has worked at CDC and can speak frankly about this. Behind the scenes, things are generally pretty stable, regardless of who's sitting in the Oval Office. And so I just will point that out to say, don't get too distracted by the hyperbole you see on TV. Just keep doing the right things and the way that you know to do them, and it'll be okay. But now there were some good things that came out of the political hoopla. There were some policy decisions that underlie that were good. And I want to point out the things that were good that happened. First of all, during a pandemic, you need the private enterprises that are going to make the vaccines to have financial risk removed, because they have shareholders that they have to respond to. And, who does the innovating as it relates to biologics and vaccines in this country? Well, it's academic institutions and it's pharmaceutical manufacturers. Generally, that's where the innovation comes in terms of the development of new products and so forth. So the government removed the financial risk. And what did they do exactly? Well, normally what happens is, if you remember back to that slide about how vaccines are produced, it's not until you get the results of phase 2 clinical trials that vaccine manufacturers would even contemplate producing or manufacturing vaccine. They would wait until the phase 2 clinical trials are over and that they're moving into phase 3 before they would even think about building facilities. What the government actually did is said, we have enough information, evidence based on previous vaccine research that's been done with these technologies, that we will give you the money to start producing them right now while you are still conducting the studies. Now, the problem is if those vaccine candidates had failed, it would have been wasted money that would have been put into the vaccine manufacturing process for nothing. But it turned out to be a good bet, because we actually had for 30 years, almost 30 years, had research going on coronaviruses, and vaccines to prevent coronaviruses had been at least 15 years in the making at the NIH previously. And the adenovirus vector vaccines have already been on the market in other forms. And so it wasn't new technology. It was a good bet. And the government removed the financial risk. They also removed regulatory hurdles that allowed for the time compression to happen. That's why emergency use authorization is a possibility, the time horizon. So if we have things in the future, that's a good thing for us to remember. Let's remove the regulatory hurdles. We don't want to remove the safety hurdles. We want to remove the regulatory, the red tape that people have to jump through. It also allowed for rapid cycle innovation and the creation of the most robust safety monitoring system in the whole world. And that was a good thing. That came out of this. We had funding for it. That was great. The biggest thing that I see as a benefit is it forced the adoption of immunization registries by all healthcare professionals and all healthcare providers across the country overnight. And that didn't exist outside of pediatrics. The only time we've had reporting routinely to immunization registries across the nation is with pediatrics, and that's the only place it's happened. And even then, there have been gaps in the reporting to those registries. So the good thing that's happened, and I hope will take root, take hold, and proceed with us for forevermore, is the use of registries across the entire lifespan. And of course, it removed access barriers for patients. The VFC program is wonderful. We've never had anything like that for adult patients, however, and paying for vaccines and financing for vaccines has been a huge debate. It was eliminated with COVID vaccine, and in the current budget, President Biden's budget actually includes funding for all adult vaccines under Medicare Part B as in boy. If his budget gets approved and signed into law, there will be free vaccines for all patients of all ages, and that's a really very, very positive thing. Now, there were some things that didn't go so well because of poor communication. there has been distrust established because politicians got out ahead of the science. And when politicians get ahead of the science, it almost always ends up hurting the science. It almost always ends up hurting those people like healthcare providers who are trying to implement the science at practice, because consumers become confused. And when people are confused, they don't act. And that is sad when that happens. And it also caused a lot of burnout. And it caused us to have reduced rates of vaccination against other important infectious diseases. And now we are having to play catch up. And so maybe any pandemic would have had that go. So what else have we learned? Well, one of the things we've learned is that the way consumers make decisions about vaccination is really funny. It's really interesting. For adults think, if you have your child and you want your child to not have the measles, just not making sure your child's vaccinated so they don't have the measles is enough. That's enough motivation. Okay, I don't want the measles. I don't want my child to have the measles. But me as an adult get vaccinated? What, are you kidding? I'm as healthy as a horse. There's nothing wrong with me. There's no reason to vaccinate me. Well, what if we gave you a free dozen of donuts? Oh, okay. Well, I'll get vaccinated. I mean, did you all see this happen? The way adults make decisions about vaccines teaches us a lesson that we have to think critically about what it is that our adult patients value, and then how can we use the things that they value to motivate them to be vaccinated. And it's not going to be the same for every adult. It's going to vary by where a person lives, by their race and ethnicity. It's going to change. There are going to be different values that different people have, and we have to pay attention to that. We don't normally pay attention to that with kids, but we have to pay attention to that going forward with adults, because from this point forward, the adult population is going to be skeptical and polarized every time a new vaccine comes to market, and you just need to be prepared to think about how you change motivations. We've also learned that patience is not an American virtue. There's no more shutdowns, except in baseball. Now we'll allow baseball to have shutdowns because that's American pastime. So we can have that. We can have that, right? But patience is not an American virtue. Now, why is this important? It doesn't matter what we personally think about the amount of time that needs to go by in order for something to happen, or that everybody needs this or everybody needs that. We have to remember that we're fighting against an impatient society. So we may know what the right thing to do is from a public health standpoint, but we are fighting against a society that may hold a different sense of urgency or patience. And so as public health workers, as healthcare professionals, we have to be thinking very carefully, okay, what do I need to do if I can't go from point A to point B in one step, or point A to point D in one step? Is there another point that's midway? Is there another point that's over here? Can I persuade? Can I influence if I can't make it happen? And so we have to think about that with new vaccines that come to market. Of course, the arguments of liberty. Anyone who hasn't heard one of these arguments in the last 24 hours in your own practice is not listening. You aren't going to make me have proof of vaccination. Why do I have to be able to get vaccinated before I eat a hamburger? The people are going to throw this up all the time. And here, of course, NOAA is now making sure before the ark fills the next time that all the animals are vaccinated against COVID. So the question is this right or wrong? No, it doesn't matter if it's right or wrong. What the question is how do we, as public health workers, make a value proposition? And going back to my earlier statement about how people make different decisions based upon their values, we as public health workers have to make population-based value judgments for our area. And we all know that this country is a melting pot of a lot of different areas that have a lot of different beliefs and ideas. So how do we influence our communities? How do we cause our communities to be able to do the right thing and get to that point based upon the values that they hold? We have to make different arguments. We have to make different justifications for why things are important. I promise I'm almost done here. The other thing is we're just not accustomed to rapid change. We're just not. I mean, if the best illustration to that is this week, ACIP has adopted 2 new vaccines for pediatric use. If you saw the clinical considerations that were published yesterday, it's quite an interesting read. It will take you a while. You'll have to read it 3 or 4 times. It is not necessarily intuitive because there's the Pfizer vaccine that has these recommendations and the Moderna vaccine who has these slightly different recommendations. And then there's the immunocompromised population, which has different recommendations and a different number of doses. And it's different depending upon whether they're 6 months old to 4-year-olds or 6-month-old to 5-year-olds, depending on the product, and 5-year-old to 12-year-olds. It is very confusing. Okay, so if we get confused by that level of trigonometry in vaccinology as people who deal with this every day, can you imagine how confused healthcare providers who are trying to provide comprehensive healthcare, not focused on immunizations, how confused they must get every day, let alone the American consumer, right? So we have got to just realize that change happening rapidly is the new norm. And we have to think about how do we message change to the people who need to leverage that change in order to prevent disease. We have to rethink messaging as it relates to any vaccine. It doesn't matter what vaccine we're dealing with. Going forward, we have to think about how do we communicate change in a way that's in a bite-sized piece that people can manage and understand and that can achieve the objective without causing harm in the process. And that's what we really have to think about. So it just really taught us that we've got to think differently. And my last slide is this one. God bless our healthcare professionals. They have been caught in the middle. I cannot tell you the stories that I've heard and the things that I've personally experienced in running vaccine clinics of this person being told this and this person being told this. Never in my life had I ever realized how influential beauticians were. Oh, well, I heard at the beauty shop the other day that my her cousin's uncle's second removed so-and-so had this happen with the vaccine. Am I going to die? And ma'am, I have no idea if you're going to die, but if I give you this vaccine, you've got a chance of living. I can tell you that. I can tell you that part. So we're caught in the middle. And so I just want to say thanks to healthcare professionals and really appreciate the work that all of our healthcare providers have done. Hopefully, I've not offended anyone today, and hopefully I've caused everyone to think. And I want to wish you the best as you contemplate how LA County has optimal immunization rates across the lifespan for all vaccines on the market, not just COVID. As you look ahead to the coming year, I just wish you the great success, and I wish you that you will think carefully about our learnings from COVID and apply them to what you've learned in the future. Thank you all very much. I'm sorry I went over.
Oh, it's okay. I'm scared of your wife. So before you leave, I wanted to make sure we acknowledge you for doing that multi-hour drive. I used to do that commute from San Bernardino every week for clinics out there. So here is a special signature plate because I saw in your office you have the collection from all the different talks you've done. This one says it is the greatest good is what we do for one another by Mother Teresa. So thank you for all the good you do. Oh, you're certainly welcome. And you make sure you give that to your wife for letting you be on the phone with me a lot. Okay, so I want everybody to take a stretch break and stand up for a minute because you know you're supposed to not sit for an hour. And we're a healthcare organization, so we're going to do that. And then we'll get to the next speaker. And thank you all for your patience in Zoom land out there. I saw some of the stuff in the chat and it was kind of funny. So now if you have to use the restroom, go ahead, but we're gonna go to the next. And even though we're running a little behind, we padded the agenda on purpose because we knew this would happen. Okay, so we're fortunate that our next speaker, for all of you who's in Zoom land, you're supposed to stand up too. So take your stretch. Our next speaker is Dr. Tehrani, and she's out there in Zoom land with all of you. And in addition to being a pediatrician, she's a specialist in pediatrics, and she does a lot of training for residents. So we're very lucky to have her. And she actually wrote a textbook, Introduction to Primary Care for Pediatricians. And she also is a member of the Immunization Coalition and has been a member for several years. So I'm going to turn it over to Dr. Tehrani, and she will be out there in Zoom land. So hopefully we'll see if this works. So Dr. Tehrani, can you hear us on the call?
Good morning, everyone.
Great. So I don't know if you want me to advance your slides, if you want to do them yourself since you're a pro at this.
If I may, I'm not sure how it will work on Zoom. I'm happy to advance them myself. Am I able to share my screen and have the group?
Sure. Let me step aside and go to the computer and let you share your screen. Hold on 1 second. Oh, Carrie's doing it right now. So we're going to try to do a switcheroo since this is very integrated technology. So she's doing it right now. So just give us a moment.
Not a problem. Thank you.
Yeah, and thanks for stepping up for the pediatricians of the world and doing this, because you're on the hot seat. There's a lot going on for pediatricians and everybody that has anything to do with kids right now. So yeah, this is the sharing one. So I'm gonna try to stop sharing them. It won't let me. This is the organization's Are you able to now? No? No, I think we're just gonna have to forward it for you. It's not letting us take their.
That is fine. Thank you.
Okay. Sorry about that. They have a very integrated system here. Okay, I'll get back to your slides. Thank you for your patience. Okay. I think I about got it back up. Okay, just tell me when to advance your slides and I will do so. Okay, I'll just advance them. Go ahead, Dr. Tehrani.
Thank you so much, Tracy. Good morning, everyone. Can everyone hear me?
Yes.
Okay. I appreciate so much the opportunity to speak, and I apologize that I cannot be there with you due to clinical duties in person, but I appreciate the technology aspect to be here with you virtually. This morning, I wanted to take a few moments, and given the time span and also at the start of all of these new pediatric COVID vaccinations, as well as ongoing efforts to improve COVID and other vaccination rates in pregnancy, I was thinking about how best to give a presentation that would be useful for all of us, whether we are in the clinical setting, whether we're community advocates, whether we work in public health, or even in our personal lives with our loved ones and family. And so hopefully after the end of this brief talk, there should be some tangible to-dos that we can all take away and incorporate into our daily activities. I do not have any disclosures. Next slide, please. And so to start, and I think Dr. Hogue demonstrated this so beautifully in his talk, I just wanted to take a moment and review the timeline of COVID vaccines with you. And so I know this is a little bit challenging potentially with the imaging. However, this is a COVID-19 timeline that walks us back. And I think the COVID vaccine is such a relevant, timely demonstration of potentially the pathway that all vaccines have taken, specifically with the many pediatric vaccines as well as the pregnancy recommended vaccines. And so timing going all the way back to 2020 when the pandemic was first recognized and official shutdown procedures and efforts for vaccination were made. However, it wasn't until late 2020 in December when the FDA granted emergency use authorization to the Pfizer vaccine and then the Moderna vaccination. Next slide, please. And shortly after that was when the FDA granted the emergency use vaccination a couple of months later in February to the Johnson & Johnson vaccine, which actually initially was thought that as a single dose, it would be more palatable to those who are hesitant for vaccinations because of its single dose status. And even further down the line, it wasn't until the summer of 2021, so almost a full 18 months after, that the FDA granted emergency use authorization initially for those children who are younger, as well as then approval about 18 months later to be acceptable for the vaccine to actually be given on a non-emergent basis to those 16 years and older. And within a few months after that, within about a 6-month period in December of 2021, the booster series for the adults and children became approved. So it was actually a relatively quick but long process before pediatric patients could actually receive these vaccinations and boosters. Next slide, please. This is a pictogram from one of the vaccination sources in the state of California, the actual COVID vaccination program that was presented in our COVID-19 and flu vaccine work group at the Department of Health Services. And it shows very simply the different ages and the different recommendations. And so for children over 12 years at this time, there are two vaccinations. There was the Pfizer vaccination that was approved. More recently now, Moderna has just hot off the press has been approved. And then for those who are young adults, which we also see in pediatrics 18 to 21, the Moderna vaccine was there. And that shows you the timeline of the different doses. Next slide, please. Immunocompromised, they have specific recommendations, including a third dose or additional dose for pediatric patients, which right now is mostly given to the Pfizer vaccine. However, adult patients can also receive the boosters as per the recommendations. Next slide, please. And so hot off the presses, and again, Dr. Hogue alluded to this, most recently, the FDA approved both vaccines with very specific recommendations for not just the Pfizer vaccine, but the Moderna vaccine as well. And so all of the healthcare systems are now in planning processes for how to roll out these vaccine recommendations and provide them to our patients. Next slide, please. And yet, despite this 2-year process, now entering middle of 2022 and having the capacity to provide vaccines to children of all ages, the vaccination rates in LA County, especially in the pediatric population, and later we'll see in the patient population of pregnant patients, remains lower than the rest of the population. And so this is an interactive public health data. This link is at the top of the page for those that might be interested in accessing, that can let you see out of the entire population of over 8 million in LA County, how many people have actually received 1 dose, received the 2 doses, or have been fully vaccinated, depending on the vaccine types they've received, and then also received their booster dose. And so specifically for the patients who are 5 to 11 years, only approximately 39% of the population of those kids has actually received their first dose. As opposed to even the 12-year and up population, who is in the 80%. Next slide, please. And this actually is even lower for children in that group who are fully vaccinated. And so for the 5 to 11 year, there's only approximately 33% of those children that are fully vaccinated. For 12 years and up, that number has dropped down to 78%, which is below the over 80% that we see. And some of the adult patient groups, that number has also decreased from the 1 dose. Next slide, please. And even despite the fact that the booster dose has now been recommended for several months, the booster dosing, specifically for the 12 years and up, is actually only at 27%. Now, with the 0.2%, there were some data challenges because there were the California Immunization Registry, where this information is pulled, was undergoing some revision at the time of this data. But even for our immunocompromised population, the fully vaccinated and the additional booster dose is actually much lower than the general population. Next slide, please. Going to pregnant people, this is an information from the actual CDC COVID data tracker. This is extremely interactive, where you can actually pull up maps and toggle between information from the beginning of the pandemic all the way in 2020 and then going through. So as you can see, this is including information for pregnant individuals aged 18 through 49 that, for the purposes of showing you the data a little bit more graphically palatable, from May 2021 all the way to June 11th, 2022. And so just to kind of orient you to the information presented, the light blue is those individuals between those age groups who were actually immunized before pregnancy. The yellow is that in-between group that were vaccinated before and possibly part of their pregnancy, and the blue is the population of pregnant women who were vaccinated during their pregnancy. And as you can see, the dark blue, especially in the current months, is actually a lot smaller than for adults comparable in that age group before their pregnancy. Next slide, please. So we all know vaccination is important. It's important to prevent illness. It's important to prevent death. There has been a lot of great evidence now, over millions of children and adults vaccinated specifically with the COVID vaccine, but barriers to vaccination exist, as shown by the lower numbers. Next slide, please. And so for me, when I start to think about barriers to vaccination, the two major arms that come up are, one, limited access to resources, and some of that to which Dr. Hoag's talk addressed and has been addressed by the current administration, and ongoing longer term work and policy and resources. But those are mostly due to disparities in health and socioeconomic status and racial and cultural perceptions, and or all of the combination of those that makes it difficult for certain individuals to become vaccinated. And yet the bigger arm, and I think the arm that we most often have to contend with in the clinical and also the community-based settings, is hesitancy and mistrust in vaccines in general. And so some of this has to do with lack of knowledge or lack of education, and this can be both at the patient as well as the clinical and non-clinical provider level. But also a lot of it is due to the increased availability of misinformation about vaccinations, and a lot of that having to do with easier accessibility to information that's present on online formats such as social media. So for the purposes of this talk, we'll focus more on addressing hesitancy and mistrust, and hopefully walk away with some tools that we can use to implement. Next slide, please. This, however, the concept of vaccine hesitancy and also mistrust in vaccines is not something that is new with the COVID vaccination. This is something that for the last, I would say 10 to 20 years even, and looking at all of the different surges in different illnesses, for example, whooping cough and other diseases due to decreased vaccination rates, has been around for quite a few years. And there has been a lot of literature talking about how to address parental vaccination hesitancy specifically for pediatric populations. And one of these examples is a 2019 national survey that reported approximately 1 in 4 parents, approximately 25% of parents, had serious concerns towards vaccinating their children. And that at that time, when this survey was done, there were also reports that said vaccine hesitancy is the leading cause of illness and deaths due to the lack of coverage of vaccines because of hesitancy and parent refusal of vaccination. Next slide, please. Interestingly enough, during the last year or so, there has also been information and surveys and evidence that was completed to show different levels of decision making. And so oftentimes, especially for pediatric vaccines, the expectation is that the pediatrician is the one to have that conversation with the family. But there's actually data and also surveys that shows that parents not only prefer to receive vaccination prior to the pediatric office visit, but that they actually think about and fully decide on whether or not to vaccinate before they have even had a chance to speak with the pediatrician. And so this study is a small study. It was done in Victoria, British Columbia, but it's very interestingly focused on a different population of healthcare personnel and workers, specifically including in the prenatal period, where that parent usually interfaces with trusted maternity health providers. And so in this small study, they actually, based on several surveys at various times during that prenatal period, they found that most parents actually chose or made a decision on their vaccination prior to the visit with the pediatrician, or even during or before the prenatal visit. And they also did some follow-up surveying regarding information and parental preference of receiving information, and found that not only are maternity care providers trusted, but parents also prefer to receive vaccine information before the baby's actually born, or they have a chance to access care with a pediatrician. And so this study seems to suggest that potentially the prenatal period may be a missed opportunity to communicate about immunization and potentially debunk myths about vaccines. Next slide, please. And so for the remainder of the talk, I wanted to focus on ways that maybe we can reframe our thinking and maybe we can reframe our efforts in addressing hesitancy at all levels. And so the first example that we'll talk about is clinical education and providing kind of myth-busting tools and resources in order to discuss vaccines and kind of battle that misinformation that seems to be making headway in a lot of the hesitancy, and also ways to make strong recommendations. Next slide, please. In a study that was done in 2018 by Fenton et al., and a lot of studies have been done using HPV vaccination as one of their main focuses, because there's also very low HPV vaccination across the nation. The study found that providers' recommendation matter. And so one of the things that they actually focused on specifically was not just that the provider made the recommendation to get vaccine, but they actually found that for both hesitant and non-hesitant parents, so even parents that generally prefer to have their children vaccinated, it wasn't just enough for the provider to say, we recommend this vaccine, but it was actually how the provider started the conversation. And so that seemed to suggest that what you say matters, but potentially how you say it matters even more. Next slide, please. But I'd like to reframe this. And so instead of focusing just on the clinician or the physician or the advanced level practitioner that does that direct interface in a pediatric clinical setting, I'd like to make the argument that the team recommendations matter. And so thinking about how we can focus our efforts into making vaccine hesitancy a part of discussions, not just at the clinician or the medical doctor, advanced level practitioner level, but also incorporating other team members, such as midwives, nursing, and other non-pediatric team members in order to improve vaccination rates. Next slide, please. As an example of how this may be effective, and actually that this exists, there was also another study that was done specifically asking and surveying midwives and also doing qualitative analyses of their perceptions about vaccination and what their perceived barriers were. And this discussed not only maternal vaccines, but also childhood vaccinations. And so in this part of the table, the expressed barriers were actually lack of confidence in communication skills or knowledge, which brings us back to the education piece. There were also concerns that there were not enough discussion times or prompts, ways to actually carry out these discussions or to cue, and also potentially that they saw vaccination counseling as another provider's role. And one of the things that they said that would actually enable that team as midwives to have these conversations was better knowledge and understanding about vaccines, and also having certain techniques, tools in order to be able to deliver these vaccines, and making sure that we discuss that midwives and other support services in a prenatal setting are actually vital individuals to have these conversations. Next slide, please. And so I think that we can focus education on tangible, effective methods. And even though it can be time consuming and even though it can be costly, there are some very tangible ways that we can carry this about. The first thing is educating our team members about resources and accurate sources of information. This is both clinical information and information that we can provide to a patient or a family when they ask it. Educating about these resources can also be important because as healthcare providers, we ourselves may have some hesitancy and we may have some questions about vaccinations in general. And so it can also be a way for us to feel more confident and to address any concerns that we may have before we try to vaccinate our patient, before we try to educate and provide that information to patients and families. And the next step is, once those resources and sources of information are shared and education about the actual vaccine itself is provided, we can educate about simple evidence-based techniques so that we all have the tools to make strong vaccine recommendations. Next slide, please. This slide shows some of the main resources of information, but it is by no means exhaustive. Part of the reason why I chose these, including the American Academy of Pediatrics, the American College of Obstetricians and Gynecologists, the CDC, the parenting website from the AAP called healthychildren.org, the Immunization Action Coalition, as well as the public health, is because they also have access to a lot of data resources that we can choose, real-time information, as well as toolkits. So if anyone in their practice or anyone in any other setting would like to actually start to have some quality improvement projects in addressing vaccine hesitance and improving vaccination rates, they have access to these resources. And so for me, I think the two specific ones that I found immensely helpful, especially with regards to providing information and handouts to family members, is the CDC and the public health website. And LA County's public health does an incredible job of actually having these handouts about a variety of topics, not just vaccinations, available in multiple languages that we can share with all of our teams and patients. Next slide, please. So we've done the education now and access the resources in order to provide our education, but what can we do in order to make sure that we can make strong recommendations? And so going back to, it's not just what we say, but how we say it. And so one of the studies that they also performed in 2017 regarding the HP vaccination coverage, and this was a randomized trial by Brewer's team, was about announcements. And so there was a technique that they actually studied that showed that not only does it save time and are easier, but it can actually increase HPV vaccination rates. And so they called that the announcements, and they call that presumptive announcements. And in the next slide, we'll talk about a technique that we can use. And so the announcement approach, and again, the font may be a little bit small on the screen and doesn't reflect well, but in general, there's actually a way to announce the vaccines that can help. And so using an example of an 11-year-old boy who is due for his HPV, meningitis, and whooping cough vaccine, so the Menactra, the HPV, and the Tdap, there was actually, the announcement approach would focus more towards a bundling of the vaccines. And so one technique they suggested is, first, you announce the child's age, then we put HPV, which is actually the vaccine with the lowest uptake and the most hesitancy, in the middle of the vaccines. So when we make a presumptive statement, so something to the effect of, your son just turned 11, he is due for meningitis, HPV cancers, and whooping cough vaccines. And we are going to vaccinate today. That rings very differently with the statement, your son's due for 3 vaccines, would you like to vaccinate? Or we think he should vaccinate, which automatically introduces hesitancy. So by saying a very strong presumptive statement, we have already gone 50% of the way in doing that. If the parent hesitates, this approach also gives feedback and a tool to be able to frame the parent's hesitancy. And so the first step is to connect with the family, because of course it's important to us to make sure that parents and caregivers have a safe space, or that the pregnant woman has a safe space, or the family members of the pregnant individual has a safe space in order to talk about their concerns and address any questions. And so we need to show active listening. We need to use all of those skills that we have in the clinical and non-clinical setting to discuss that. And of course, based on the information that we receive and the source of a parent's hesitation or the questions, we can address. And so specifically for HPV, there are messages for hesitant patients, which is on the lower left side of this, that can target any type of question. And so this is a tool that actually we have put in practice at my site in order to provide this information. And this tool even gives you an exercise, and you can do a role play session with the team in order to provide training on this announcement approach. So this is one way that we can address hesitancy. And this can be tailored to any vaccine. It doesn't just have to be the HPV vaccination, but it can be tailored to COVID vaccines. It can be tailored to the flu vaccine. And then the messages would just change depending on the information related to the counseling about that vaccine. Next slide, please. So we've talked a little bit about providing clinical education, about making strong recommendations, but what about non-clinical settings? And how about even some creative ways that we can address vaccine hesitancy from any sector that deals with immunizations and families? And so some of the examples of that are holding town halls, for example, setting up town halls with the school system, having providers and different community members address questions directly from parents, give presentations about vaccines. There can be public announcements regarding, or PSAs as we call them, in order to improve vaccines. I'm sure everyone has seen some of the HPV vaccination materials that's posted by the different vaccine companies and also by public health related to cancer prevention in children. They're very creative. They actually have accurate information but grab attention and open up conversations with providers. There can also be increased social media presence. So whether it is from organizations such as the American Academy of Pediatrics, or whether it's from immunization coalition organizations, or even hospitals and clinics that have this format and available information. And then also next, an example is is advocacy groups, and also partnering with community-based organizations, for example, American Cancer Society or even ICLAC. Next slide, please. And so I just wanted to give you an example of some of these efforts, the first of which is actually one of the residents who was on their advocacy rotation. Now, this is a rotation that all first-year residents at Harbor UCLA Pediatrics experience. And so during the height of the pandemic, Dr. Ryan Usui was on his advocacy rotation, and there was discussion once the vaccinations were actually approved for use in pediatrics of how can we share and disseminate information in a friendly format in order to offer information to families who may be hesitant. And so at that time, the vaccine had just been approved for 12 to 18 years old. And Dr. Usui created this very creative cartoon and made it very interactive. And he basically shared information about the vaccine as a recipe of how to make cupcakes, and discussed the effectiveness of the mRNA vaccine and how those vaccines translate to our immune system and create an army that recognizes a crown that's on this cupcake that's created by the recipe. And this cartoon was actually posted on our organization social media website that's accessed not just by patients and families, but it's also accessed by other members of our teams in the clinical setting. And so this is one example of kind of sharing that social media presence and being creative in addressing vaccine hesitancy. Next slide, please. I also wanted to share with you an example of a parent who actually, this was featured in Public Health and other news reports in February of 2019, where a parent named Kim Nelson, who at the time lived in South Carolina, discussed her experiences with vaccine hesitancy and moving into a community that tended to have much lower vaccination rates across the board for childhood vaccines, including the measles vaccine. And so she actually created an advocacy group with a lot of online presence for families, for parents, called South Carolina Parents for Vaccines. And she used this as a forum to not just provide information, but also to really battle some of that misinformation and be a source of support for parents trying to make a good decision for their child. And so this is another example of how a parent or even just a member of the community can step into this role and be that voice, because oftentimes parents will trust other parents who've shared that experience. So I thought this was a very unique, interesting attempt at discussing vaccine hesitancy. Next slide, please. And so in short, vaccines are an important public health issue. And we all know this, and we've heard about this specifically with the recent COVID pandemic. But vaccination rates continue to be impacted by hesitancy. And there are some evidence-based methods that we can use to address hesitancy, and specifically education can be effective. But we need to incorporate the entire medical team and even try to reach beyond the clinical setting in and of itself to use all of the opportunities that we have to vaccinate. Next slide, please. And so I hope that this has afforded you with an opportunity to take a couple of ways, and hopefully not super hard ways, to incorporate discussion and to come at addressing hesitancy in a different way. I don't know if we have time, but thank you for your attention. I'd be happy to take any questions or discussion.
Are there any questions in the room? Otherwise, okay. She's checking the chat right now too, Dr. Tehrani.
Thank you so
But
much,
we will-
Tracy, and thank you for advancing the slides and staying up there for me. I appreciate it.
Sure. And for our speakers today, we have a vaccine passport where you can put your passport in, and it also has a place for the vaccine card. And so all the speakers, including Kedran, because I see Dr. Abraham getting excited. And the reason for that is, for those of you, like I traveled around the world as a Navy captain's wife, and you think you can put something on your phone and pull it up. Some of those places you cannot do that. So I tell people, if you don't take your hard copy, you're going to be in trouble sometimes. So this is a gift I will mail to you, Dr. Tehrani, and any of the other speakers that are here today will also get that. So thank you for taking the time. We're going to give you a great hand for that. Okay. I know we're running behind, but I want to give you guys a bio break because, again, we're a healthcare organization, and I don't want to be the person who has gotten you in trouble. So we're going to take 5 minutes. So exactly 11:17, we'll start back with the next round of speaking engagements, which will be Kedran's Community Spotlight. So thank you, and take your 5-minute bio break.
Elena, I'm going to do one of your PEs this week. I can only do one.
But I walked by this morning and I'm like,
Okay, it's approximately 11:17 or exactly 11:17, and we're going to let Kedran take the community spotlight. But before I do that, I wanted to acknowledge two important people who were part of who are leading the vaccine program at the Department of Public Health. And the first one is Laura Fowler. And I know she doesn't know I'm going to say this, but thank you for all you've done. She actually manned the department as a leader, and it was instrumental to me personally to make sure that people who had challenges, providers, community organizations, got support for the vaccine. So I have a special Vaccine Saves Lives pin for you in one of these shot pins and the little vaccine holder, because I know you're going places with your passport because you're always traveling. Thank you. Okay. The second person I want to recognize is our new leader, who is Andrea Kim. So she just came on board to be in charge of the vaccine program at the Department of Public Health. And she's the first person who I've met in public health who says, I need to see you in person. So I have a special one of the vaccine cards for you. And thank you for your support and coming on board. Thank you. And you see me in person now. Okay. So with that, I wanted to acknowledge also Madeline, who's our intern from IBM's Watson Foundation. She's the first intern Immunization Coalition has had, and she's been with me weekends and nights doing everything in between. So thank you. And she's taking pictures, going to build our new website. So thank you. Okay, Kedran, you're up. I would like to give an introduction, but I really can't. Any organization that does 500,000 vaccines to every nook and cranny in LA, all I can do is kiss your feet. That's all I can do. So I'm going to get out of your way, let them speak for themselves, and I'm out of your way because I know not to get in your way, Dr. Abraham.
Oh, Lord, no.
All right.
Okay. I know there's we're all mixed and in different parts of probably even the city, the county, some folks on Zoom, some here in the room. So we're going to try to bring the energy. I know it's not always easy to feel it when you're staring at a screen or in this room here at the California Endowment, but we hope to really provide an engaging little window into our world at Kedran Vaccines. Give me one moment while I get our presentation up. Reverend, do you want to?
I could. But again, good morning to everybody who is in the room and on Zoom. I'm Reverend Danisha Beaver, serve as the program manager for Kedran Vaccines in partnership with Charles University of Medicine and Science. And we are certainly delighted to be with you today to share our work, our practices, our values, our traditions to help us to do the work that we have done, and knowing that we cannot stop. And this is just the beginning of a great, great work that lies ahead and all the work that we're doing in the room together.
Okay, great. So Reverend's going to try to keep me grounded, and I'm going to try my best to slow down. But I did want to cover a lot of really important information as fast as we can. And we're really excited for Dr. Veal and for Azidia and for everyone that has invited us to be a part of the Immunization Coalition of Los Angeles. We've already learned a lot this morning from our colleague who's informing the Advisory Committee on Immunization Practices. We've learned from our pediatrician this morning. And so we just want to add a perspective. We definitely want to bring here today present the Black and brown perspective around vaccinating Los Angeles County and a lot of those considerations you've already heard about, but really what does that mean in our day-to-day lives right here at Kedran and in South LA? There are no conflicts of interest. We're not receiving any funding from the pharmaceutical industry. We really hope to just cover in our objectives just what we've accomplished so far, what are some opportunities for vaccine delivery moving forward, and also how we're going to expand to revolutionize healthcare delivery, democratizing and ubiquitizing really healthcare within our community. Just really briefly, who we are, Kedran Vaccines in South Los Angeles, where we have now vaccinated over 300,000 people with the COVID-19 vaccines. Yay! Tested hundreds of thousands more. We have deployed hundreds of mobile clinics where thousands have been vaccinated, with a large part of that being within our schools and making sure that we really reach the hardly reached, as we talk about. When we look at the 5-year-old to the 18-year-old, that's really where we've been focusing a lot of our attention. That's what we hope to share with you guys here today. Reverend, did you want to add anything?
Thank you, Dr. Abraham. You don't have to pry the mic away from him. In terms of our team is intentionally diverse. We represent every spectrum when it comes to sectors. So medicine, public health, faith-based, international relations, government, military. We are also bilingual. We want to make sure that in every community that we go to, that we're able to reach people where they are. So we're very intentional about having a staff that is representative of also the places where we go.
Okay, so really our story you may have heard, back in December 2020 is when our vaccine journey with COVID-19 really began. And that's when on Christmas Eve, I picked up the phone and I demanded from the Department of Public Health, where are our vaccines? We had this conversation with Dr. Shaw, and then we worked our way up to figure out where were our vaccines. Where were they? And so, and I tried to be sensitive about this because on one hand, I want us to push. And I think that's part of what we have to do when we work to achieve health equity, is really jumping up and down, waving our arms, writing SOS in the sand, and really demanding what is ours and making sure we take what is ours in our community. We want to balance that with knowing that our sister Department of Public Health, our lock and step partner throughout this whole journey, has been there along the way. So whatever happened and why our vaccines didn't come as early as maybe we would have liked are things we want to address moving forward. And that does get into, just really understanding the priorities of whether our quaternary and tertiary academic medical centers are always the first priority location, retail pharmacies, grocery stores, but people may be getting their healthcare from community health centers. They may be seeking information, guidance, and even vaccines from their church or their schools. And so really, how do you get those vaccines to where people need them now and first, and to those trusted partners whose daily work is opening their doors, their hearts, their minds to the community in a way that maybe a very large hospital system can't. They open their doors to their patients, they open their doors to their staff, but may say everybody else needs to wait. And we saw that those kind of decisions can be deadly and fatal. So we really want to just encourage, again, the strategy of getting these vaccines to community health centers was so critical in really expanding. I think Kedran is just one of those stories, but you see many partners, including St. John's and others, who've worked tirelessly to get these vaccines out. But once we, righted those challenges, by New Year's Eve, we had gotten 50 doses, then 100, then 150. Back then there was Dr. Claire Jerishow, who we were interfacing a lot with, and we had actually brought media partners with us to the Department of Public Health when we asked for our vaccine. So I know that was, ruffled some feathers, but again, these are the types of approaches that sometimes makes that difference. And I think it really highlighted for our community, as we heard earlier this morning, we're gonna really take what's ours. So you change the framework from, this is a conversation, is it really right for me, for give me my vaccine, and you see how quickly that motivated the community to come out and wait in line. People waited for days for these vaccines early on.
Awesome. So one of the things that we had to do was disrupt the traditional model of the system, right? And so we know, unfortunately, when vaccines was first rolled out, no fault of anybody's own, but it was in a tier system in terms of how people can receive vaccines. But it wasn't those in the tier system who needed the vaccines. It was those people in these geographic radiuses who need those vaccines and they needed them immediately. And so a part of that radical disruption, and we have to be okay saying sometimes you have to radically disrupt a system. We had to make a decision to radically disrupt that system. And so we began to disaggregate that data by race and ethnicity. That had not been given to us yet. We just began to look at heat maps, look at the data, drive around, see what was going on, and see who needed vaccines the most. We began to utilize zip code and household-based strategies. How many people are in the home? If you get one vaccinated in the home, we could get the whole family vaccinated in the home because each one reaches one and a family makes a difference. And so once we understood what it was the family dynamics, who was making the decision about the family being vaccinated, our goal went to a household strategy. Who is the influencer in the household that can get the entire family vaccinated? In addition to that, we began to again look at the heat maps and geo and GIS data as it became available. But if it was not available, we had our staff on the ground. We had our staff driving around the neighborhoods, driving around the communities, going to the churches, going to the stores, going to facilities, going to homebound, seeing where the need was and making it happen.
And I definitely want to credit Dr. Beal for her work really as championing the Vaccine Equity Committee at the Department of Public Health within the county that was so critical at really encouraging us to explore and experiment as we needed to. When we looked at those zip code based pilots where we said anybody from our zip codes, walk right in like you're boarding first class at the airport at LAX. Same thing happened with those household-based strategies where if there was one positive COVID in that house, that already tells you that house is at high risk. Why wouldn't you allow that entire household to come and get vaccinated? So those were really exciting ways to kind of disrupt, as you said, the current model. And then we realized March 26, 2021, that we were going to have to take these vaccines on the road, take the show on the road. And we knew right away with the mayor's office, with LA Fire Department, with the Department of Public Health, we had to build up this mobile fleet. And so then we launched this campaign, the Live, Work, Worship, Play, Vax at School, and Reach the Homebound, where we were devoted to going to housing developments, factories, churches, and houses of worship, where we went to community centers and parks, and where we went throughout the county's schools, and then also making sure that we were able to get to people that were homebound. And that's, again, how we really worked hard to, at that point, get our hands and feet really wet in the equity work, which we knew that if we stayed in ivory towers, if we stayed in our institutions, and just hope that people would come to us, we were really missing a very important opportunity. And, I can't say this enough, but really the history of our community, the distrust, the mistrust being at the heart of it, putting people and the communities really at the center of the care we're delivering, it was so important. So we acknowledged, with the Kedran way, that this is not an experiment on our people, that really these are life-saving essential medicines for everyone, including Spanish-speaking patients in our community, including African Americans in our community. We really needed them to know these are not experiments like the Tuskegee trials that denied men access to treatment for syphilis. This was not the abuse of Henrietta Lacks cells. This isn't the undertreatment of Black pain or the medicalization of racism in this country. In fact, there were Black and brown people in the clinical trials, and you need to know that, and you need to know that you should be in line to get these, not just rich people, not just white people, not just Asian people, as we saw their uptick much higher than our community. So that really drove a lot of our work, our passion, our advocacy when we saw those disparities, that injustice in our community.
Awesome. And what we do know, as it was mentioned before, we were really dealing with multiple pandemics at the same time. And so you're dealing with a socioeconomic pandemic, you're dealing with a medical mistrust pandemic, and then you're dealing with a misinformation pandemic that really ran wild during COVID-19. And so it was very important to us, for Dr. Abraham, myself, our entire team, that it was not just them seeing us vaccinate, but also seeing us doing the direct communication. Certainly infographics, flyers, all of those things are good, but this was really about being boots on the ground, one-on-one conversations. And so you would see us in the room with your vaccination, but you may also see us on Zoom because we were coming on doing the health educational sessions, doing the outreach to churches, to schools, to families. And so when we showed up, the vaccine clinic became a call to action after we had webinars and town hall meetings with individuals. That same week, we would show up and do a vaccination clinic at the various places we were working. And so they worked in tandem together. So not just communicating about the vaccine to those academic partners who know about it, but we actually needed to go into the room. We would go into church. We would disrupt services, worship services. Dr. Abraham, myself, we would come on during the sermon time, live on TV, talk about vaccinations, and then have a vaccination clinic right after that service ended. But that was the type of disruption and intentional engagement that was needed to do this work.
That's really why I love having a preacher right by my side constantly. Not only is she a minister, but she has a master's in public health. What beautiful way to bring our faith, faith in our religious beliefs or spiritual beliefs, but also truly our faith and knowledge, our trust in science and public health and medicine, to see that beautiful healing ministry. I don't take it for granted at all, because you really have been able to engage a whole sector, as we've seen at the county level, especially Dr. Veal, with engaging the Black church. And now we've seen many of our, Latinx partners bringing the Catholic community along, bringing the Muslim community along as well. So there's a lot of opportunities that we miss when we keep people out of the room. And that's really one of the take-home lessons here is who's in the room, who's not in the room. And as I teach medical students and residents, we're going to bring our folding chairs, we're going to bring our folding tables, we're going to politely nudge people and say, we're going to, make room for everyone, because their voices are not always heard. And it's not always our responsibility or the appropriate way to speak for others. So I think one of the questions we could say structurally is who's not in the room, because they do have voices. We need to make sure that they're in the room so they can speak up for themselves. And I hope that's something we continue to work on.
And I'll add to that to say that it's also important that when it comes to the faith-based community, there was challenges even in that space, right? Science against health, against religion, and what people believe or not believe, or religious exemptions and things of that nature. But our duty and responsibility is to show that if you believe Genesis 1:1 says, in the beginning, God created, well, that's innovation and that's creation. And so it is not science against religion. Science and religion work in tandem together, because the Bible and many faith tradition and practices books of influence are full of creativity and innovation in that practice. And the importance is bringing those scriptures to life and say that we're not working against each other, but we're working together for all the things.
Okay, so I know y'all weren't thinking on Tuesday morning y'all were all going to go to church, but I really just want to say that this has been nothing short of a miracle. Many of the allegories, analogies that we used, we felt that this was the great flood, and we were all going to have to get everyone on board on that ark. And we had thousands of people waiting outside, and we never knew how we were going to get through the day. It felt like the miracle of loaves and fishes. We never knew if we would have enough, and that was really important. We really saw a lot of dark days, but we were able to get through it. And so I don't want to discredit any of that, because we all in this room, I'm sure many of you on Zoom and people outside of this forum right now, have really rolled up their sleeves. We've gone through a lot of heartache and pain. We're going to have trauma. We're going to need a lot of healing from what we saw and what we did, but that is literally what it took. And it felt like altar calls. We literally went up there and we preached the gospel of these life-saving essential medicines. And because of that, people came down the altar, rolled up their sleeves and got their shot, including religious leaders who then were able to bring their flock along. So just really want to underscore that importance. Things that we really believe in at Kedran: culture is important. When we talk about Black culture, Latino culture, institutional culture, what is our mission? What is our aim? And so the Kedran way, where we treat people like people, our mantra this whole time, we had several mantras, was to engage, educate, vaccinate, activate the community. We're going to mobilize people. We're going to empower community health workers and all the non-traditional healthcare team members, aunties, grandmas, teachers, coaches, policemen. We saw community leaders. We saw firefighters. We saw there were so many people that came together that it wasn't just relying on your doctor, your pharmacist, your nurse. Sometimes it really took someone else who was a non-traditional healthcare role to really be able to help bring people along on this journey. So just really want to highlight that keeping people at the heart of the work, the dignity and respect that we have, seeing the humanity in every individual, that kept us going 7 days a week from morning till night, until we knew that our patients experiencing housing insecurity had access, to make sure people living with HIV were prioritized in all of this. And I know that was no easy feat for the Department of Public Health, but we do want to just continue to challenge our colleagues in the public sector. We want to continue to challenge those Accenture and other consultants and Blue Shield and third-party administrators, when they sit in their luxurious Bay Area, wonderful kitchens with their chandeliers behind them, telling us how to get these vaccines out in South LA, sometimes maybe we don't have a clue. And sometimes maybe in those whiteboard exercises and those white papers and theorizing, we've maybe left some folks out, and that's really important to keep in mind.
You can see he's very passionate about that whiteboard. Okay. But also the main thing important is that we know that we're in a season now that we're moving beyond just COVID-19 vaccines, right? And so we've been talking about how do we get vaccines for all children. We know during this pandemic and this time, many of our children are behind in their school-based immunizations. Adults are behind in their regular primary care health services. So what do we learn? We take the lessons that we've learned and the work that we've done, and now we move it forward. We can't just say this work was for COVID-19 only. So what does that mean? That means now taking primary health care services on the road. That means taking maternity and child health development on the road. That means adding back HIV and AIDS work on the road as we are doing COVID-19 vaccine. So it's not if or, but it's both and. And so now we are moving towards a model of engaging all of these services while we're on the road. We're going to a place now where we have to meet people right where they are. We cannot wait for them to come to our doors. We cannot wait for them to make an appointment. We need to go to them and be present right where they are.
Yeah, and I know we're limited on time, but really one of the big reasons why we're here today is to talk about our Vaccineland solution to target, 5 to 12-year-olds. So we'll get to that in a moment, but definitely the immunizations are at the heart of it, especially as right now we look at the 6-month to 5-year-olds, different types of challenges, engaging parents differently, knowing that vaccinators may not be comfortable with little persons and really how to make them comfortable and understand that they may not be able to communicate in the same ways, but they experience pain and we need to make them comfortable and we need to deal with little patients with the same dignity and respect that we would our older or larger patients, and those are all real considerations that we're trying to figure out. So I'm going to move along because I know I want to get to the actual Vaccineland solution. I did want to say when she talked about the show on the road, taking this vehicle out, it's a platform. It really is a vehicle that we need to be able to tack everything else on. And that means bringing, public health services, primary care, prevention. When we think about the climate crisis facing our community, when we look at reducing gun violence, all of these are things that in a mobile medicine, street medicine, mobile public health infrastructure, we really can tackle. And if we invest in that now, that is your pandemic preparedness. And so, again, I really want to stress the importance of our public health, public department. But we need to have, just like we have FQHCs, you need to have private sector, nonprofit, public health infrastructure that's ready to roll out. And we're going to miss that opportunity if we close this all down and it all goes away. As we're seeing right now, we're not going to be ready for that next awful pandemic, which, we know can happen and will happen because of the changing times, the climate, all of that. So want to figure out ways that we can keep this public health infrastructure, especially in the private sector, the not-for-profit sector, alive and well so that our Department of Public Health doesn't have to be swamped and feel like they're the only ones that have to champion this. We can all champion this together as a community, whether you work at the DPH or not.
Right. I will add to that that we cannot end this presentation without acknowledging the partnership of Charles University of Medicine and Science, a historically Black graduate institution, medical institution in South LA, that Kedran and Charles University have partnered together in this work. And so their CDU street medicine team, our Kedran mobile vaccination team, we work in tandem. We are one band, one sound. We go out together and we do the work together. Our branding is on both of our vans and our logos. We want people to see that these two HBCU historically institutions that were made in South LA to address acute psychiatric mental health services and to bring diversity in the medical care professional have partnered together to create change in South LA. And so we're so grateful. And many of the pictures you see a lot of their staff with our staff because we have been working in tandem together, both academic and the community health clinic association.
Okay, so I know that we're out of time now and we definitely want to answer any questions. So drop them in the chat box and we'll definitely do our best to respond to them. Just wanted to show lastly as we're closing our Vaccineland product, and I'm not going to spend too much time on this, but this is really an opportunity. Everything we're talking about, how do we do it now to bring it to elementary schools, middle schools, high schools? And so this really was the opportunity to address a lot of the issues that we had just described around lack of access, misinformation. We hear about hesitancy, but really it's making sure that we're present and accessible to people, and that can overcome a lot of those challenges, distrust, and outright refusal of these solutions. We need to create a space where people are ready and willing to accept these solutions. And so really, when we look at all the different partners that are coming together, we're going to go through LAUSD, Inglewood Unified, and others to really bring this solution. Kids are going to get a chance to walk through this and engage the science, the information. There's going to be a lot of interactive learning and entertainment. And then somewhere along that journey, they are going to get vaccinated. While they wait, they're going to continue to learn. We're going to encourage them to join the healthcare workforce. So we see so many benefits to really this more holistic, whole person, whole community approach to vaccines, where people feel safe and protected getting their vaccines. And we're working on trying to bring, this experience to as many schools. We even really have this amazing prototype that Mr. Wesley here has worked on. We really want to figure out ways that kids can leave with really being engaged in game theory and using their brains and their bodies in ways that maybe they're not always given the opportunity. So this is the journey we're on now, and we look forward to bringing it to a school near you. Reverend, did you want to add anything about Vaccineland?
Sure. So definitely Vaccineland is one of our highest endeavors that we're interested in doing, and ensuring this model is something that can be replicated not just in Los Angeles, but across the country as well. But this is Small World Meets Vaccines. This is your Disneyland experience meets the vaccine space, and not just for COVID-19 vaccines. That's what we're granted for to do it today, but this is really for vaccines for children, but also their parents, also their families, because this is both an educational experience and a vaccination experience. And so that game board that you saw is a person coming into the experience, receiving their information, receiving their passport, utilizing gaming theory. We know that our children spend about 70% of their time on video games. And we know the importance of gaming theory. But what's most important to them, and what parents remember, is they remember Candyland, right? And so we base this off of Candyland because that was something parents remember while their child is playing some of the new video games coming together, but something they can meet in the middle on, something they can engage and learn with one another. So we're very excited about this. We're looking forward to partnering with all of you to implement this work, but we are looking forward to doing this with LAUSD and some of our other partners really, really soon. But we're hoping, again, that this model of care can go to schools, to houses of worship, to parks and recreation, taking the same model that we did on the road in our mobile health, providing vaccines for all.
All right, so with that, we'll go ahead and turn it back over to Dr. Veal. I know we've kind of gone over our time, but we do want to be here. We'll stay after if you have any questions. We're looking forward to working with all of you as we continue to vaccinate LA County. Thank you.
Yes, thank you.
It's so funny, all these people I met when I came to LA County Public Health, now I'm knee deep in vaccines. So I wanted to just acknowledge all of the effort, all the collaborations. There's about 1,500. When I started, we didn't have any. So a long way, and I actually met Dr. Richard Dang, who's up next. He took a strange call for me to help me over in the USC area when we were having some crisis. So it's funny how it's been 2.5 years and I feel like I'm friends with people. And I also want to recognize Susan, who's here from the LA County Office of Education. And she's one of those people I didn't think I'd ever see in person because I know how busy she is. And she's a member of the Immunization Coalition as well. So thanks for taking my call. So thank you, Dr. Abraham, Reverend Donisha, and Wesley. And we will move forward with Dr. Dang. So if you want to come up, Dr. Dang, and oh, come to the mic. I'm sorry, I forgot to do that. My brain isn't functioning.
I just wanted to acknowledge Kedran too as the recipient of our Acip Challenge, which was sponsored by the Department of Public Health at the state level. And we had the opportunity to bring together a wide range of for-profit, nonprofit, lots of different participants, and they had to very quickly put together and propose a project. And so we had 3 winners, and that's the wrong word because it was really the result of a lot of collaboration and partnership with ourselves as well. But they were the recipients of a $100,000 grant to move forward with Vaccineland. We're so excited that you are so holistically taking and approaching vaccination from the point of view of children and families and communities. So congratulations. We're so pleased that you were part of that. And we hope to have some other the Acip recipient grantees too in coming meetings to acknowledge all of their work. So thank you.
Okay, I'll turn it over to Dr. Dang, who's very modest. He's actually the president of the California Pharmacists Association. And I asked him would he do me a solid and be an officer for the Immunization Coalition. And it's funny, he said yes. So thank you for doing that when I know the Pharmacists Association has been exhausting for you. So I'll turn it over to you. And
Thank you, Tracy.
your slides are somewhere. Where you got it? He's much more high tech. I will just get out of his way. But thanks to everybody who keep on taking my calls, and then I ask you to do something. So one day I'm going to give you something back. Thank you.
Thank you, Tracy. Hi, everybody. So good to see all of you, many familiar faces, and what an honor to follow Dr. Abraham and Reverend Beaver as well. It takes me back to the early days when I had the privilege of joining them for one of their town hall webinars. So really great speakers today from Dr. Hogue, Dr. Tehrani. We heard really great information. My focus today, and I'm very acutely aware of the time, I will get us out on time, I promise. My focus today is to really talk about some recent CDC updates, especially to the immunization schedule with a focus on adults. Dr. Tehrani focused on pediatrics, and I think focusing on adults was something I wanted to do. And so much focus for the last 3 years has been on COVID-19 and COVID vaccines that, as we've heard already, pediatric rates have gone down, adult rates have gone down. And in the background, if you weren't looking, a lot of changes have actually occurred in some of the vaccine recommendations for adults. And so I just really wanted to take this time to highlight some of those changes that we need to be aware of as providers and community advocates, because there are some pretty significant fundamental shifts in how we approach the vaccination for certain vaccine preventable diseases. I have no disclosures to report. I am the president of the California Pharmacists Association and now the vice chair of ICLAC. Our learning objectives, like I mentioned, is really focusing on new updates that have occurred with a specific focus on pneumococcal, hepatitis B, and shingles vaccination. We heard from Dr. Hogue the role of FDA and CDC, so I'll skip that portion. So with the vaccine updates, this is a talk that I do often actually every year for our students at our school and for our association. So this is a summary of all the different FDA vaccine products and ACIP recommendations that have occurred over the last 3 years. And again, if you weren't paying attention, you would think that the ACIP only focused on COVID, but actually look at all the other vaccines that they were focusing on. And the ACIP normally has 3 meetings a year, and last year I think they had like 50. So they were very, very busy. And so there's some really interesting products on here, some new pneumococcal vaccine products that we'll talk about, a new hepatitis B vaccine, but also vaccines for smallpox and monkeypox. And that was in 2021, before this current monkeypox outbreak. Tick-borne encephalitis vaccine, dengue fever vaccine, Ebola vaccine, lots of activities. So that's just a summary of the different things that we can be aware of if you are interested in looking to see what that information looks like. I would like to remind everyone that the CDC releases an annual update to its immunization schedule, usually at the end of January, early February of each year. Sometimes they're just cosmetic changes, but again, this year there's some pretty significant changes. This is the schedule for the adults, and I've boxed up the 3 vaccines that I would like to focus this afternoon on. So again, shingles, zoster vaccine, pneumococcal, and hepatitis B. And we'll go into some detail. There were some other changes to other vaccines as well, but not enough time to cover them all. Now, with pneumococcal vaccine, there were 2 new products that were introduced into the market and approved by the FDA and recommended by ACIP. And those were the 2 that I bolded. So we have PCV15 and PCV20. So we have 2 new conjugate vaccines, 15-valent and 20-valent. And so now that is in addition to what we've previously had on the market, which is the 13-valent conjugate and the 23-valent polysaccharide vaccine. For those who are interested, I've mapped out the different strains and what's in what, because sometimes that is a little bit interesting. But I will just point out that the 23-valent does have some unique strains that are not found in the other products, and that the new 20-valent also has some new strains that weren't found in the previous products as well. So, with the introduction of 2 new products, my first thought was, oh, great, this is going to get even more complicated because pneumococcal vaccine recommendations were already really complicated. And this is the timeline of those complicated vaccines. And so many vaccine providers and public health officials here, you are very familiar with this, but over the last decade, there have been very rapid changes and sometimes conflicting recommendations on which pneumococcal products are recommended, especially for our elderly population. There was a period of time where everyone over 65 needed to get the 13 conjugate, and then now recently they didn't need to get the 13 conjugate. And so that introduced a lot of confusion. And now with the two new products, my concern is complications. Let's take a look at the rates of invasive pneumococcal disease. This chart really just kind of summarizes the different rates for the different age groups. And I think what we want to focus on is that top dotted line. That is the incidence of invasive pneumococcal disease for the for the adult and elderly populations. And the message to really take home from here is that our adolescent population has really low rates of invasive pneumococcal disease because pneumococcal vaccines are a routine pediatric vaccine that they get as they grow up. For many adults, that was not a vaccine product that was available as they grew up in their childhood. And ACIP tried to remedy that by making those recommendations in elderly populations. But we see that even after 2014, when they made that recommendation to introduce conjugate 13, that the rates of invasive pneumococcal disease really plateaued. They didn't decrease, indicating that that strategy didn't really work. And so the hope is with the new products that are introduced onto the market, that will be able to help us reduce those incidents of disease in that specific population. Here's a summary of the current recommendations, but I actually want to highlight this slide. I kind of simplified everything for you. So on the left, we have what was previously recommended, and on I guess you're right, is what's currently recommended now. The good news is it is simplified. The ACIP's goal for these recommendations was to unify and simplify the pneumococcal vaccine recommendations, because again, it used to be very complicated. Depending on your indication and your age, you would get multiple doses of conjugate or polysaccharide, and it got confusing, frankly, right? So now with the introduction of the new products, we're really focused on just the use of conjugate 20, conjugate 15, and polysaccharide 23. Essentially, conjugate 13 only now has a role in pediatric vaccines and not in adult vaccinations. And they've also simplified it where any age group that's indicated has the same recommendations, whereas before, if you were 19 to 64, if you were 65, there were kind of different recommendations on which one to initiate first. Now, for all adults who are indicated, so that includes any adult aged 19 to 64 with high-risk indications, or any adult over the age of 65, the recommendation is to receive either one dose of conjugate 20 or one dose of conjugate 15, followed by a polysaccharide 23. So those are the two strategies that are being recommended for pneumococcal vaccinations for adults. And again, that is going to really simplify the process because now we don't have to think about the timing and the number of the interval, the number of doses that have to be administered. And so this will hopefully make it easier for our healthcare providers to really recommend these vaccines to the specific population. There are no changes to who is being considered high risk as the adults aged 19 to 64. That still includes adults who have chronic medical diseases like asthma, who are cigarette smokers, who have chronic lung disease, or who are immunocompromised, et cetera. And the other question that we want to ask ourselves is, well, what do we do with patients who have a history of pneumococcal disease already? Again, do we revaccinate? Do we restart? Are they considered complete? And this is a nice little handout that CDPH has put out that helps us summarize some of those information. So the two options that we discussed before, the conjugate 20 or conjugate 15 with polysaccharide 23, those are for vaccine naive adults who've never received any pneumococcal vaccine before. But for those who have previously received pneumococcal vaccine, you can see the strategies listed under B and C. For B, individuals who have previously received a polysaccharide 23, they simply need to follow up with one of the conjugate vaccine products, either 20 or 15, and then they're considered to be fully vaccinated. For those who have previously received a conjugate vaccine, they will follow up with either preferably the polysaccharide, or if that's unavailable, they can follow up with the conjugate 20. But in general, for that specific population, the polysaccharide 23 would be the preferred product. Okay? So this again simplifies that item. And then for any adult who's already finished a complete series of conjugate or polysaccharide, no additional doses are recommended at this time. And here's the list of adults who would be considered high risk, which we've already discussed. Next is hepatitis B. I think this one's, for me, really exciting because it presents a really big opportunity for all of us to have a really big impact in vaccination rates for this particular disease. I do want to summarize with some of the available vaccine products. The one that was most recently introduced and brought to market was PreHevbrio. The other items we've already had on the market for the last few years. PreHevbrio is a recombinant vaccine, and its call to fame currently is that it does protect against 3 specific hepatitis B antigens, which is different than the other vaccine products because those only protect against 1 specific hepatitis B virus antigen. Clinically, we don't know if that's going to make a huge difference yet, but the idea is that with the other vaccine products, there has been a high rate of non-conversion for some adults. And the thought is that the introduction of additional antigens would close that gap to prevent that high population of having that seroconversion. The other products on here, Engerix and Recombavax, are kind of our legacy hepatitis B vaccines. And then Heplisav is the other relative newer one, and its call to fame is requiring only 2 doses to be fully vaccinated as opposed to 3 doses, which PreHevbrio, Engerix, and Recombavax would require. As we take a look at the incidence of hepatitis B vaccines, we also see a really interesting trend here where the adult populations have higher rates of hepatitis B than compared to our younger adolescent population. And again, that makes a lot of sense because hepatitis B vaccine is the only vaccine that is indicated at birth that every single infant and child and newborn receives. And again, that was not a recommendation that was in existence for our older population. And so we're really seeing the great benefit. If you look at the bottom, which represents 8 to 19, it's pretty close to 0, right? Plateaued, stays really low. But for adults, especially our older adults, we still see pretty high rates of hepatitis B vaccine. And again, that represents a huge opportunity for us to intervene and to prevent these preventable diseases. So here's a summary of the recommendations, but again, I like simplifying things. So previously, the recommendation was simply that, a recommendation. If you want to get hepatitis B vaccine as an adult, if you have risk factors, or if you desire immunity, you can get it. What has changed now is essentially a universal recommendation for adults, mirroring the universal recommendations for our pediatric population. And so it really went from, well, you can get it to you should and need to get the hepatitis B vaccine. So with our hepatitis B vaccine, it is now routinely recommended for all adults aged 19 to 59, and then also recommended if you're older than 60 with higher risk factors. So really targeting that adult age group that has that high rate of hepatitis B vaccine. And again, I think a pretty fundamental shift to how we recommend the specific vaccine with our adult population. Again, I think now, whereas before we were maybe more passive, now thinking about how do we make more active recommendations and proactively develop programs that are incorporated into our clinical practice or our mobile units, and how do we educate adults on the need of having these hepatitis B vaccines, where before we weren't necessarily as invested in making sure every single adult was vaccinated for this particular disease. So for me, I think this one's the most exciting because I can see a lot of opportunity for us to really make a big impact. Next is with shingles. Here's the recommendations, but again, summarized here. With the shingles vaccine, the exciting piece here was that before it was only recommended for adults who are aged over 50, but with the recent change from the ACIP, it expanded the age group to include all adults over the age of 19. Specifically, adults aged 19 to 49 can receive the shingles vaccine if they are or will be immunocompromised. And so that introduces a new population for us to recommend the shingles vaccination for to prevent morbidity that is associated with this particular disease. And those who are immunocompromised are of particular interest because they are the ones who are more likely to develop significant morbidity from having the disease, and they're the ones who are also more likely to experience recurrent disease once they've already had the shingles virus. And so now we have that additional adult population for us to provide the vaccination for. And also, again, if you were only focused on COVID, the other change that has happened is the live shingles vaccine is no longer available and no longer recommended. That was something that the ACIP did make a preferential recommendation against years ago, but now it's officially off the market as of 2020, and we only have the recombinant vaccine, which is Shingrix. I'm throwing a bonus one in here really quickly, HPV. So HPV, I think really cool too. The big change here was that it used to be only FDA approved and CDC recommended for up to age 26. But with the new approvals and recommendations, it can now be given up to age 45. So that increase in the upper limit of age is really helpful to help catch up any adults who may benefit from the HPV vaccination. And it's under the category of quote unquote shared clinical decision making, which really just means having a discussion with your patient and seeing if they would benefit based on their lifestyle characteristics and any additional risk factors they might need. But again, now HPV vaccine can be administered to adults up to the age of 45. Lots of other vaccine updates that I didn't get to cover. I do want to point out that dengue vaccine is now available. It is on the routine recommendations for children and adolescents, and specifically for children living in US states and territories where dengue is endemic. And that includes a lot of our US territories like the Virgin Island and a lot of other territories within the southeast hemisphere of our country. So something to keep in mind for those patients. All right, so that was a really quick highlight of some of the big changes, but I just wanted to get you thinking about opportunities that we can have for adult vaccinations, and these were the ones that had the most significant updates since the last year. Thank you.
Okay, we're down to the end, but I wanted to make sure, Dr. Dang, you got your passport, because I know you're always traveling somewhere with the vaccine card holder. Thank you for all your help. Okay, so we're down to the end, and with that, I want to thank all of you for even coming today, because I know you had other things you could be doing, but this is really important. So I wanted to close just with a couple of things that we have going that you should be aware of, because someone asked me, what is all that stuff over there on the table? Well, for the first time, the Immunization Coalition, the steering committee, voted to support immunization, a pandemic curriculum for kids. So we have a pilot program, interestingly enough, with a faith-based organization and a clinic in South LA. The clinic is not in South LA, it's a virtual clinic. So I didn't count you out. And so the pilot program is actually starting in July. And we have weeks of things about hand washing and bacteria. So we have taken any volunteers that want to participate. So it's going to be every day for a 3-week period. And the kids are pretty excited because they're getting lab coats and goggles. And they also didn't know that about the bacteria on your hand. So they're excited to see that. That was probably an exciting thing. The second thing is October the 18th, we have set aside a date, don't have content yet, to do another one of these forums that will be hybrid because we don't know what will happen in October with the surge. So we assume a lot will be virtual. So we're going to do another one. And if you have any content ideas, we're certainly open to that. And so with that, I will close. I feel like I've been to church and I've been to clinic training. And I will close with that and thank you all for coming, and you can mingle or go forth. And thanks to all of those in Zoom land who stayed the course. We didn't hardly lose anybody. So thank you. That's it. It's a wrap.